What I want to talk about today is our submission to the National Guideline Clearinghouse. And so we've titled it the IAOMT Position Statement Against Dental Mercury Amalgam Fillings. But the actual title of the topic doesn't actually fit on most of the brochures. This is actually the title that we had to submit it. And we spent a long time trying to decide what to actually call it, because a lot of the search terms that people use to actually find it will come up as part of the title. So that's really why the title's so long. It's actually called the International Academy of Oral Medicine and Toxicology Position Statement of Dental Mercury Amalgam Fillings for Medical and Dental Practitioners, Dental Students, and Patients. Oh, AGD disclaimer. I should have said this right from the beginning. I do not have any financial interest or product in my talk or with any companies offering grant monies for this continuing dental and medical education program. Okay, so there's a few of us that worked together on this. Jack Call, Phil Sukel, Amanda Just, and of course myself. And I can't say enough good things about the people that we worked with this on. They were really invaluable in lots of ways. Jack really kept us organized and on track. He was terrific that way. Phil, he was really the energy and the enthusiasm behind it all. Amanda wrote most of it. She was really quite incredible, and I think I was just the looks. Now you may ask why I'm here. Why am I the one if actually doing the speaking of this? And it really comes down to one reason. When people are having a meeting, make sure you don't miss the last 15 minutes of it, because invariably that'll be when they decide who's going to be the one speaking. So that's why I'm here with doing it today. Now before I get too far into this, I want to talk a little bit about what's the purpose of both this paper and what I want to talk about today. Our great organizer, Kim, asked me, what's the program content? Is this clinical research? Is this documented research? Or is it clinical application? And in essence, I wanted to check all three of them. The reality is I'm a clinician. That's what I do. That's where I like to be. I like to work with patients. And so much of what I want to talk about today is how to actually utilize this position statement in our clinics. How do we actually use it? So that'll be what we want to talk about. So now, this is a little bit about the IAOMT history. Many of you probably know more about this than I do, but back in 1984, when there was 13 dentists that got together and didn't like the idea of using mercury. That's been around a long time. Dentists have hated using mercury from its inception back 100 years even before that. So they started, though, what they really want to do is they said, let's talk about the science. What's the science behind these mercury fillings? Why are we actually using it? Why are we letting it be grandfathered into our kids and our children? So they wanted to go forward and they looked at what the science was behind mercury fillings. Shortly thereafter is when Murray Vimy and Laura Scheider came up with their several different papers. Number one was where they put mercury fillings into sheep. And he showed unequivocally that mercury from mercury fillings actually escapes from the fillings and is implanted in the body of those who have it. That was refuted by much of the associations. He then did the same thing with monkeys, and then he did the same thing to show that the mercury fillings that come from the animals actually goes into the fetuses. So that was all the way back in 1984 and 1985, following up to 1990. Following that, I loved hearing Dr. Richardson this morning. He did those two risk assessments, and I thought he did a good job talking about what risk assessment is. So that's another, these are two fellow Canadians, I should say, which I'm pretty proud of. Yeah. So he went forward with Health Canada, talked about the risk assessment of mercury in general in the population and in our environment. What's that risk associated to us as people? And then he goes on to say, what's the risk from dental amalgams? Another risk assessment, that was back in 1996.
Group of Canadians that's supposed to advise the government on mercury fillings.
So this is a
Are they
newsreel
safe
from Canada.
or could they be a hazard to your health? Here's our health specialist, Brenda Craig.
Dr. Murray Vimy is so disgusted with Health Canada and its panel reviewing a report on the safety of mercury fillings, he's quit the panel in protest.
I would like to see mercury fillings or dental amalgam removed from the marketplace. It's a material that's 50% toxin, poisonous mercury, and the medical evidence, without question, shows that there are certain health risks associated with these fillings.
One of the world's leading experts on mercury fillings, his research has inspired at least 3 countries to phase out mercury fillings.
I think Dr. Vimy, who's done a lot of research on the health effects of mercury exposure, was very disappointed that other people on the committee did not accept his research results as being conclusive and demonstrating that dental amalgam is actually causing health problems for people.
Mercury fillings have been linked to kidney disease, Alzheimer's, mood disorders, and diseases of the immune system. And last November, a Health Canada report suggested that the number of mercury fillings be limited in children and adults. Now, 3 months later, the panel of industry representatives, health officials, and dentists that Vimy once belonged to has rejected the report as unscientific. It's a view supported by the Canadian Dental Association.
At this point in time, we believe that silver fillings with their components are safe to be used in the general population, other than for those individuals who have allergies, specific sensitivities.
But Vimy says many of the panel members simply aren't qualified to understand the science of mercury fillings.
The flip-flopping back and forth on this issue is almost identical to what's happened with the breast implant and the tainted blood.
Health Canada says it will come up with a policy on mercury fillings sometime this year. In other countries where mercury fillings are being phased out, they're not recommended for use in pregnant women, children, or people with certain health problems. Whether that happens in this country remains to be seen. Brenda Craig, CBC News, Toronto.
From AB.
Now, some of you who know Murray Vimy may know that he doesn't look quite like that anymore. And you may wonder how long ago that was. So, that was, any guesses? Oh, wait a second, what happened to me? Very good. 27 years ago. That was about 1986 that newsreel was going. And yet we're still here in the new millennium having the same arguments with the same people. You know, what got me into the IAOMT happened years ago, I remember, and I don't remember how it came about or how I got the letter or how it ended up, but I read something from Boyd Haley, who wasn't here at the conference, which is really too bad. And in this letter, he says that he feels like he's had a 10-year argument with the town drunk, where you go over and over and over again. And as I read that, I said, that's the guy who I got to get to know, right? Because that's exactly what it was. And we're still on it today. We still feel like we're arguing the same cases that we were arguing before on this treadmill. My brother always told me, he gave me sage advice. He said, you never argue with an idiot. He said, because they'll drag you down to their level and then beat you with experience. So similarly, sometimes when we argue with these pro-amalgamists, we're on that same treadmill and we're getting drugged down to their level. So what are we going to do? I guess that's one other thing to say. Just the absence of evidence, and I'm speaking to the choir here, but the absence of evidence certainly is not the evidence of an absence. Right? When I don't see my children and they're all being very quiet, it doesn't mean everything's going well and hunky-dory. Usually what happens is they're creating havoc and they're being quiet so I don't catch them. So when we don't see what's going on, usually there's bigger problems ahead. So in case you thought I was being too Canadian-centric, this one is from the World Health Organization. This was a policy paper they put out in 2005, and they said a few interesting things, particularly in the last one. In it, they're talking about mercury, and they say mercury is a naturally occurring heavy metal. They go on to say that mercury is toxic, especially when it's metabolized to methyl mercury. It may be fatal if inhaled or harmful if absorbed through the skin. Around 80% of the inhaled mercury vapor is converted in the blood. My favorite part is down here. Adverse health effects from mercury exposure can be tremors, impaired vision, hearing, paralysis, insomnia, emotional instability, developmental deficits during fetal development, and attention deficit. And the last part, recent studies back in 2005 suggest that mercury may have no threshold below which some adverse effects do occur. So even back in 2005, the World Health Organization published an article to say there is no safe limit of mercury. There is no safe amount that we should be taking into our bodies. Okay. So what do we do now? What do we do now that we're on that? And that's really what brought about this paper. That's why we went about doing it, is this motto of show me the science, while good and valuable, the science has not been enough. The politics to get through that science is just not enough. So now we've used multiple other veins, and I think they've been really helpful. Whether we start doing public pressure, we had a good discussion by Jerry this morning. I think another good one is Randall Moore with all he's doing with what you put what in my mouth. Now we're starting to get a lot more public pressure. And that public pressure is really starting to move some of that policy. We continue to do research. The IAOMT is one of the forerunners at actually funding valuable research. So that's also really been valuable. This is actually intended for clinical practice. So a clinical practice guideline is intended for those who are clinicians. There's a large gap between research and clinical practice. In research, it's easy. They can spend hours and hours and days and months and years on a specific problem that in the clinic we have to deal with very quickly. And so they often get very theoretical in research, that in an ideal world, this is how it should take place. They have large statistics and large sample sizes that allow them to make these conjectures. In clinical practice, we actually get to see what happens when we try those things on patients and how to actually implement it. And I think that's the really big difference. So we can see the problem is our sample sizes are very small, and the lifespan, or how long we can look at things, is also very short. So there seems to be a bit of a gap. So I guess that's really the point of a clinical practice guideline, is to assist clinicians in their clinical decisions in a realistic manner that isn't really theoretical. So clinical practice guidelines can be defined as guidelines that are systematically developed statements to assist practitioners and patients in decisions about their health care in specific clinical circumstances. I think many of us have been in situations where we've taken out mercury fillings on patients, and there's a lot of studies that suggest that doesn't help people's health, that there is no impact on people's health when you remove mercury from their bodies. Yet many of us in our experience have found that that is not the case, that there are specific instances where they have been benefited greatly, and there's no change except that the mercury fillings have come out. You could say the same thing about cavitational lesions. What's the long-term impact of a cavitational lesion? What is it after 60 years? There's no research or evidence on it. We can't actually say. But many of us have taken it out, have removed cavitational lesion from somebody, allowed them to heal, and all of a sudden their ailments that they had disappear remarkably, miraculously. But unfortunately, we just don't have large sample sizes and to make that into research. So, clinical practice guideline is a way that we can actually guide how clinicians go about, and that's what I want to make sure that we're talking about, is how to actually use the clinical practice guideline. Okay, so then clinical practice guidelines are, if they're for use by clinicians, to allow us to actually go forward, how are they developed? So that brings us to really evidence-based medicine. Now, evidence-based medicine, I think there's a lot of thoughts about what evidence-based medicine is, and lots of misconstrued about what evidence-based medicine is. Evidence-based medicine is not a strict, predetermined set of rules that a clinician must follow, predetermined by some organization or group. Evidence-based medicine, although sometimes projected that way, that we just have to follow and do what the research tells us, is actually a list of 3 different things. It's a combination of the best research available, whether that's a large randomized controlled trials or something smaller, even anecdotal evidence. What's the evidence to suggest a certain line of treatment or modality? Number 2, what's the clinical expertise? That's based on a clinician's experience and what he's done throughout his patient population. How a clinician may act with a senior population may be very different from somebody who's a pediatric dentist. So evidence-based medicine also uses the clinician's experience to guide his research decisions. Last, patient values. What does a patient want? What do they actually need? And what are they going to allow you to do? And that's based on a lot of their culture, age, and such. So I have a patient in my practice. So how do we actually make evidence-based medicine useful? If I followed what it is not, I have this one judge who's in my practice. I just saw her 2 weeks ago. I thought she was an interesting case. So she came in, and she's got a heart condition, so she told me she needed to be pre-medicated with antibiotics. Now, I'm not a big fan of antibiotics. And the recent guidelines tell us that we don't have to pre-medicate people anymore because it's changed. So for things like heart murmurs, no reason to pre-medicate them or with prophylaxis. She told me she needed it. The evidence would tell me I don't have to, and if I strictly followed evidence-based medicine, I would tell her she needs to be on antibiotics. Then she goes on to tell me, but she wants to take them. Then she goes to tell me that she's had 3 bouts of bacterial endocarditis, that she's been on IV antibiotics 2 weeks ago, that if I'm going to touch her gums, I need to give her antibiotics. When she gave me that kind of information, I agree with her. I think she does need it. So that's how we apply evidence-based medicine, is based on their values, my clinical experience, and my willingness to take on litigation from a lawyer about antibiotic prophylaxis, and what's the research? What's the evidence available? What's her risk for taking antibiotics? And what's the risk to not take antibiotics? And that's how we use evidence-based medicine. So clinical practice guidelines really give us the flexibility to be clinicians, which I think is important, with the evidence to back it up. Okay, so that's a clinical practice guideline. The next part is the National Guideline Clearinghouse. What's their purpose? The National Guideline Clearinghouse is really a publication company. What they want to do is to provide physicians and others and health professionals accessible mechanism for obtaining objective, detailed information on clinical practice guidelines. Essentially a way to actually get access to the data. They do it, they have grants from the government to do so. They're supported by our government. Whether that's good or bad, nonetheless, they allow the dissemination of clinical practice guidelines. So it's a vehicle we want to take advantage of to see if we can add more nails to the coffin of mercury fillings. So what's an acceptable clinical practice guideline? There were four things that they asked us that were required to submit to have a clinical practice guideline accepted. One, it needs to be systematically developed. We can go into more detail about that. That's where we're still working on to get it actually published. Is it needs to be repeatable so that somebody else doing the same thing will find the same answers over what we found. Number 2, it has to be produced by an organization. So that makes the IAOMT a really nice organization, a nice vehicle to actually produce a clinical practice guideline, because me as an individual can't publish one. It has to come from an organization with a board. Number 3, it has to have corroborating documentation. Well, big deal. So that means we have to actually provide the research. If you're going to make a statement, make sure you can back it up. Essentially following the same motto as the IAOMT, show me the science. Last, it needs to be available in English. Again, that should be okay. So those are the requirements to actually submit a clinical practice guideline to the National Guideline Clearinghouse. So we went forward and did that. This is just the cover page of the clinical practice guideline. And really, there's some incredible parts about this, about the guideline. Not only is how detailed it is, but that it actually utilizes and provides an access to the science behind the position. So in it, now that we can get into it, we'll talk about there's 4 main objectives that we want from this guideline. Number 1, we want to end the use of mercury fillings. That's the position of the IAOMT since 1984. We're still on that same position. Number 2, we want to understand the risk and scope of mercury fillings. How far, how broad is our net for the risks associated with mercury fillings? Who are we impacting? Both patients, both staff, and the physician or the clinicians. Last, we want to establish the benefits of having a mercury-free practice and actually define what that term means. What is mercury-free, mercury-safe, and biocompatibility? Last, we want to establish safe removable practices. When this becomes submitted, it will actually be accessible by all clinicians. It's free to access it. So much of what we try to accomplish when we wrote the paper was to make it so that when people searched for various search terms, they came up. so that more than just people in the IAOMT will have access to the information and the science. So when somebody says to me, look, you don't have enough science to say that mercury fillings are bad for you or that they cause harm, I want to be able to provide that information and tell them they're wrong. That when they call me a quack because I don't use mercury, I can turn around and call them a quack because that's what quacks use, is mercury. That's how they got the name in the first place. So this is a nice vehicle to allow us to do that. We started a bit with the historical background. Now the historical background does more, it starts with the U.S. regulations. What are the regulations from the U.S. about mercury? How did they come about? Then it goes into the FDA. How did the FDA play a role in that, in mercury use and continue to be used in dentistry? Then it goes a little bit into the global regulations. Which countries have disallowed mercury use or put a ban on it, and which ones haven't? And I think the IAOMT is doing great things with many of its programs to fund many of the nations that are looking at removing mercury or banning it completely from their nation. Next is the risk assessment, and we heard a little bit about that this morning from Dr. Richardson, which I thought was marvelous, where he says millions of Americans exceed the intake of mercury vapor considered safe by the EPA. Now, that happens both for people who have mercury inside their mouths, which is what Dr. Richardson was talking about this morning, in addition to those who remove mercury fillings from people's mouths and the patients that are sitting there in the chair having the mercury fillings removed. We regularly exceed it. I think there's some great research that shows that many of the protocols or many of the systems that we use to reduce mercury exposure have a significant impact at reducing mercury exposure to patients and staff and the clinician. Then we spend a little bit of time talking about the precautionary principle. What is that? And who bears the burden of proof? And what does that mean? So the precautionary principle can be stated as follows. When an activity raises threats of harm to human health or the environment, precautionary measures should be taken even if some cause and effect relationships are not fully established scientifically. In this context, the proponent of the activity, rather than the public, should bear the burden of proof. Which means, rather than the public trying to prove that mercury fillings don't cause any harm, because mercury we know is a neurotoxin that causes long-term impacts on people's health, it should be the mercury producers showing us that it does not, which they have failed to do so far. So that's the precautionary principle stated in the article. Now, in order to actually succeed, what we need to do is actually ask for 4 interventions, or what are we going to do to change the way that dentistry is done. So there's 4 interventions that we talked about in the article that are required. Number 1, terminology. What are we calling these things? So there's lots of options you can call it. A lot of patients call them silver fillings, right? A lot of physicians may call them silver fillings. We don't call them silver fillings. It confuses the issue. And in fact, silver isn't even the largest component of the filling, so we really shouldn't be calling them silver fillings. Amalgams is the name that it's been termed. We don't like using dental amalgams or amalgam fillings because most people don't know that amalgam means mercury's there. In fact, if anything, they think there's very little bit of mercury in those fillings, when we already know there's almost 50% mercury. So rather than call them those, we could call them dental mercury amalgam fillings. You may question why we put amalgam back in. The reason is because that's what a lot of people have been called in history. And when they do a search, we want to make sure that this article comes up so we can tell them, you make sure mercury is part of the name, given that it's the largest constituent of the fillings. Now, in clinical practice, you may not want to do that. At least I don't. It's too long of a name. So calling them dental mercury amalgam fillings just takes too long. My patients fall asleep before I'm done. So rather, I usually just call them mercury fillings or mercury silver fillings. Any 3 of those would be just fine. But we want to avoid the use of camouflaging what the principal constituent of these fillings is. We also talk about what it means to be mercury-free. Many dentists call their practices mercury-free because they no longer place mercury fillings. And so we talk about what that means, that even though it's impossible to make your mercury, or I shouldn't say impossible, very difficult to make your practice mercury-free, because you'd have to tell patients that have mercury in their mouth, please not to come into your practice. We may call them mercury-safe. Mercury-safe being defined as practices that actually remove mercury in a way that prevents exposure to or minimizes exposure to patients, staff, and the practitioner. We also talk about biological or biocompatible dentistry, where not only are we concerned about what's coming out of their mouth, getting the mercury out, but we're also concerned about what's going back in. Is it biocompatible? Is it helpful for that individual on an individual basis? So all that becomes defined in this article. Second, frankly, mercury fillings just shouldn't be used. It was a bad idea to begin with. It's still a bad idea. And so we go into a little bit of detail about stopping the use of mercury fillings in dentistry. It was interesting as I looked at a lot of this to find the amount of mercury that comes off a mercury filling. We know that it's the number of micrograms. But if you were to put mercury on a little pedestal right here in this room, we'd all have to leave. It would be too toxic for the room, and you'd have to have some environmental cleanup agency to come deal with it. But if you put a mercury filling on this, it's perfectly fine, so they say. Yet the amount of mercury that comes off a mercury filling is between 11 to 25% of liquid mercury. It's almost a quarter. It can be up to a quarter of liquid mercury coming off those mercury fillings. That was done back in 1989 by an individual, and I thought that was remarkable. He said it usually happens. Oh, am I gone? No, I'm back. And the reason so much mercury comes off these fillings is the difference between gamma 1 and gamma 2. Now, before I bore you later on in the afternoon about what gamma 1 is and gamma 2, all you need to know is that mercury, during its corrosion process, translates into gamma 2, which is when it attaches to tin rather than silver. And as a result of that equilibrium between the two, it vaporizes between 11 to 25% of the same as liquid mercury. So really, it just shouldn't be used in dentistry at all. Number 3, special populations. There's also special populations that should never have mercury in their mouth. Now, at least that's being accepted by some of our regulatory organizations, that they say pregnant women and small children shouldn't be used. We say that that special population list is actually a little bit larger than those 2 classifications of people, or those with kidney problems, that it's actually a lot larger than this. And rather than go through each one of these, which I'm not going to do with you today, the list is just a lot longer. And so, now many would say, well, are those things really true? What's beautiful about this article is in each of those special categorizations or those special populations where you talk about allergies or Alzheimer's disease or Parkinson's disease or kidney disease, beside each one is a reference for the paper that describes how mercury causes problems in these special populations. So for me as a clinician, this is invaluable. This is my arsenal. This is where I can turn to when somebody says there's no evidence to suggest there's a change in hearing loss due to mercury fillings. You can say, forget it. There is too, and pull up the article that says so. So that's probably one of the primary ways that I want to use this in my clinic, is having the references available for the naysayers or the ignorant who haven't actually looked at the research but are just towing the status quo or towing the line. So that's true for both the at-risk populations, goes on for patient exposure. If you want to know all the articles, there's, I don't know, another 100 of them there, or 75 articles listed there. How about genetic predisposition? We know that some people have predilection to mercury toxicity, that they have an inability to actually excrete the mercury that is absorbed into their system. You want to know what papers they are? There they are. And these ones specifically relate to CPOX4, ApoE3 and 4, BDNF. So now we actually have evidence that supports the view that we've been holding for all these years. Or actually we have the compiled evidence. We've had the evidence for a long time. I guess now it's compiled in a nice way for people to access what the references are for these things. Lastly, we want to talk about safe removal. That's one of the other interventions we'd want to do. And we know the IAOMT is very good about teaching us what safe ways are to remove it, and what does that mean for exposure for a patient. Okay, then we go into outcomes considered. So now you may wonder, what's the format for this? Why do we put all these in? Essentially, the format's dictated by the National Guideline Clearinghouse. So they make a few titles, and we fill in the blanks. And so one of them they talk about is the outcomes considered. So we need to recognize that individual differences do occur with individuals who get their mercury fillings removed. Some people we know have miraculous events where all of a sudden their life changes, they're better as a result of mercury coming out of their mouth. Other people, however, have no change. We see no difference in their symptoms as a result of mercury removal. So we talk a little bit about that. We also expect to see a decrease in mercury symptoms, although not always, and we may see a temporary increase in mercury exposure, both in their urinary and fecal output. So, then they ask us what are our major recommendations. Really surprising, don't use it. It was a poor choice. Number 2, use safety precautions when you're in the presence of mercury. And last, the public health. So in public health, we talk about both the workplace environment. What are we exposing everybody who walks into the workplace with? What are we exposing our patients to, both those who have mercury fillings and those who we're going to use the instruments on afterwards after it's come out of the sterilizer? How about the exposure to women and children and others? Or finally, what if you've got an allergy to mercury? So we make recommendations on each of those. There are a few additional subheadings at the end of the article. What are going to be the potential harms of implementing this clinical practice guideline, of actually removing mercury, or removing mercury as a dental option? And so we talk about some of the potential harms, both in cost and that there's additional training that needs to be done for many practitioners who aren't used to using with anything but mercury. Are there any contraindications to removing mercury, removing those fillings? That's similar, we already talked about that. Women of childbearing years, lactating women, or small children, right? Those would be the contraindications for moving forward. We also talk about qualifying statements. So what are qualifying statements? That's where we discuss the current debate on mercury fillings. Those who say that mercury fillings are safe and those who say that mercury fillings are not. We actually take a little bit of time to talk about their viewpoint. Why? So that they understand that we understand where they're coming from. What I think they don't understand is the impact that removing mercury fillings can have on an individual's life. Before I end, I guess that's about the end of it. I wanted to thank the group that I worked with. They really were quite incredible. They're a good group to work with. Both their leadership, their enthusiasm, and their abilities were really quite stellar. And thanks for having me here today.